welcome to you, Andrew. You're welcome to share your screen.
Thank you very much, Jette, and to the organizers. And I hope you can see that in its illustration format, yes?
Yes, we can.
Excellent. So thank you to the Danish Diabetes Academy. The Danish investigators and their funders have been really great supporters of this question. Welcome to everybody. I'm delighted to see 30 plus participants. I recognize many of your names. I see one or two I see one from Hawaii. I don't know if she's actually, what time of the night it is there, but welcome to you. What are my credentials to be on this talk, opening up this wonderful program of work? I've been involved in this area since really 2009. I'll show you a slide where there was breaking news really about insulin analogues, and this led to the formation of a group called the Diabetes and Cancer Research Consortium, which at that stage was mainly to do with pharmacoepidemiology of anti-diabetes drugs and cancer risk. I'll share a little bit of that with you, and I've shared that group really since 2010. And from that group, we then formed a diabetes and cancer study group within the EASD in about 2013, 2014, under the presidency of Andrew Bolton at the time. So before I start, I'd like to thank everybody who's been involved with this work over the last 10 years. There is really a lot of fascinating things to cover. By definition, my introductory talk will be quite generic, and there'll be subsequent talks that will dive a little bit deeper into certain cancer types. I've no financial relationships in the last few years in this area. This is humble Manchester in usually a wet northwest of England. We are optimistic that we are coming out of COVID pandemic. Our vaccination programs have been very encouraging in the UK. I hope in other countries it's the same. As Jette says, I hope we start to see each other this summer in face-to-face. Would be fantastic. I'd like to acknowledge the lower three slides here, which is really the coming together of Cancer Research UK, the University of Manchester, and the Christie Hospital Cancer Hospital, which forms the Manchester Cancer Research Centre. And really to appreciate some of this story that I'm going to describe, this is a slide or the schema from a book chapter that was published some 3 or 4 years ago, the textbook of diabetes. And it shows this relationship, this central relationship of obesity, type 2 diabetes, and cancer. So these are two shared, obesity is a shared risk factor for two diseases, diabetes and cancer. That's where the kind of common thread is here. You'll also see that there are anti-diabetes drugs mentioned here, and I'll come back to this in subsequent slides. And I'll also point out the importance of taking smoking into account, because smoking is an effect modifier of the association between obesity and cancer risk. And of course, smoking is also a risk factor for type 2 diabetes. And so you'll see in subsequent slides, I often show the data for never smokers because it's often a cleaner data set to interpret and to understand. So these are the key messages that I'm going to be delivering today, and I will show these again at the end of my talk. So I will cover cancer risk and point out that a lot of the cancers that diabetes is associated with are what we refer to as obesity-related cancers. I will also talk about the association between diabetes and cancer-related mortality, and pointing out that there are a number of caveats that go with this relationship. I will touch on a huge area of pharmacoepidemiology to do with anti-diabetes drugs and their implications in cancer risk, but really just give you a flavor of what will come later on in talks. And again, I only have an opportunity to give you one slide on the genetics. I was asked to touch on genetics, and it will be mainly in the area of Mendelian randomization, which allows us to look specifically at causal pathways that may be important in this relationship between diabetes and cancer. So this is a slide of from Cancer Research UK website, and it shows the what's referred to as the obesity-related cancers, of which there are 13 types. And you can see them listed here as pink circles and blots. And you can see that the size of each of these circles relates to the attributable proportion. So this is the number of these cases that are related to an elevated BMI, a body mass index. And this work I was fortunate enough to be involved with. The picture above is from IARC. For those in the cancer world, they'll be familiar that IARC is an important organization out of Lyon in France. It is basically the cancer arm of WHO, and it does a number of reports every year which link exposures to cancer risk. And in 2016, we came together as a group of 21 scientists. We had a lock-in for 10 days, and we produced this report, which was published in the New England Journal in late summer of that year. And that basically still stands as the core number of cancers that are linked with cancer, with elevated BMI. So there's generally a recognition that type 2 diabetes, because it is an obesity-related chronic condition, that the cancers that are linked with diabetes are also the same as those that are obesity-related. And this huge umbrella study from John Ioannidis' group, published in BMJ in 2015, concur and attest to that you'll see many of the cancers in the lower part of this plot. Now, this is an umbrella review of meta-analysis. So it is a meta-analysis of meta-analyses. And what you can concentrate is on the blue plots here, the blue horizontal bars and their squares. And you can see that many of the cancer types, endometrial, pancreas, gallbladder, kidney, esophageal, these are all obesity-related cancers, and they turn up as high hazard ratios when you relate them to BMI. So we have a fair amount of evidence that a fair amount of literature that links diabetes with these cancer types. This particular paper was quite controversial because it also tried to look at the red arrows, which are known as prediction intervals. So this gives a further amount of uncertainty to these estimates, and it takes account of the between study heterogeneity of the studies that were included. And you can see that in some of these red horizontal lines and arrows are quite wide. And this particular group questioned whether there was truly a link between diabetes and cancer that was independent of other things. And there was a very strong and controversial editorial that went with that from the Harvard group led by Ed Giovannucci, who's a senior investigator in this area for the last 25 years. And they shot a lot of holes in the methodologies that were used in this umbrella review, and came out quite strongly, as you can see by the footnote there. Strong evidence points to an association between diabetes and major cancer types. We've done some work here in Manchester, and these next two slides are former PhD students. And this is a really snapshot of a huge amount of work, which shows the relationship between BMI taken typically within 6 months of the diagnosis of type 2 diabetes. And these are incident cohorts. And these are data taken from the primary care database here in the UK, the GPRD, and the cancers are linked via the cancer registry. And what you see here is that the BMI categories are across the top of this table. And I have looked here at the cleaner groups, the never smokers, and looked at the changes in BMI and their associations with cancer risk for all obesity, these 13 obesity-related cancers. And these are divided by men and women. This is an important point, is we should always be looking at these stratified by men and women. And the key summary estimate is in the extreme right-hand side here, where it shows the risks per 5 kilograms per meter squared. And you can see that there is a significant signal for women, but not a significant signal for men. And that difference in men and women has been shown in many, many studies when we look at the relationships between diabetes and cancer risk. And the same is true here when we look now at cancer mortality. This is another PhD student that finished last year. And again, we see that per 5 kilograms per meter squared, there is an increase of cancer mortality. And of course, cancer mortality is conditional on you developing cancer in the first place. And you see that there is a signal for women, but not for men. This is a group from Imperial, led by Jonathan Pearson Stewart, who are, you'll see this paper and in a subsequent paper that's just been published in the last month, which I will go back to some of his work, which expands this issue around the numbers of cancers and the cancer deaths in patients with diabetes. So this study is a very large study published in Lancet Diabetes, and it attempted to look at things at a global level. So we're now looking at all countries in the world, and we're looking at the numbers of cancers that are attributed to diabetes and BMI. And there were 4 outcomes from this, 4 outputs. The first one was that attributed to diabetes itself. The second, that attributed to BMI itself. And then there were 2 combining BMI and diabetes. And the first one is a conservative estimate. And the second is if they are independent of each other, there will be an additive effect. So you'd have a greater number. And I'm sorry you can't see the total number. It's just gone off the screen here. But the total number in the lower bar comes to the order of 800,000 deaths, or sorry, 800,000 new cancers worldwide per year. So that's just short of 1 million cancers that may be potentially avoidable if we have better control of our weight and better control of our diabetes. So that's a huge, huge number. I said that the second item is now to look at mortality and survival. There are subtle differences here between mortality and survival. So when I use mortality, I'm usually referring to the context of a cohort study where you've got an exposure, participant is followed up, they may have cancer in a later diagnosis, and they subsequently go on to have the outcome of mortality attributed to the cancer. So you're relating the initial exposure to the subsequent mortality from cancer. I will also refer to survival, which takes your first time point as the diagnosis of cancer, and then looks at death from cancer in that context, and asks the question, does diabetes impact upon that pathway? There are several studies now, and this is one just from Manchester, published some 4 years ago, which looked, this was mainly to do with ethnic subgroups, but it looked at the breakdown of cancer, of underlying causes of death, and of which cancer, you can see, was in that particular study was the second biggest cause. And again, this is using the GPRD primary care database in the UK, and it's linked with the Office of National Statistics. And the important thing to see here is that this is a comparison. These were matched for each other, and these are type 2 patients versus non-type 2 patients. And the important column is on the right-hand side, where you can see, not surprisingly, overall, there's an increased mortality with patients with diabetes of a 2-fold. And for cancer, this is a 1.6-fold increase. And for cardiovascular disease, it's of the order of 2-fold. So this is relatively old data. You'll see in a minute that things are changing recently, and I'm going to come back to that in a second. And this is what I was alluding to, where the changes are. And this was just published in the last few weeks. And this is again from this Imperial group. And this is using, again, GPRD primary care data here in the UK. And what the group have done is that they've now looked at the trends of the causes of death over the last nearly 20 years, from 2001 to 2018. And you see 4 categories of patients. You see the patients with diabetes, the patients without diabetes, and you see them recorded for 2001 and 2018. So if you take the first 2 columns, you can see that overall, the number of deaths from diabetes is a lot higher than those patients without diabetes, consistent with my previous slide. But what you can see here, that in 20 years, there's a trend towards reduced mortality in patients with diabetes. But that's also true of the general population. So on the right-hand side, you can see that the number of deaths have gone down in the non-diabetes population as well, which is a recognized fact. We're getting fitter, and our mortalities are reducing. What the study then went on, it stratified things at many levels, but you can see here that the color scheme are showing you the major causes of death. And you can see that in the early years, in the first column, that blue is the predominant cause of death, and that is for ischemic heart disease. And the lighter blue is for stroke, and the near gray blue is for other circulatory causes. So overall, the cardiovascular diseases were by far the biggest cause of death in 2001. Whereas cancer is the red and the slightly more purple color, mauve color, is a smaller proportion. But when you come to 2018, it now has actually overtaken the cardiovascular diseases, and it is now combined a bigger number than cardiovascular diseases. We did a not dissimilar piece of work, again using the GPRD, and this is a letter we wrote to the Lancet last year. And these are patients now who have cancer, and these again were matched. They're first of all stratified by men and women, but they are matched this time on cancer. So we have a matching with and without cancer, and within that there are people with and without diabetes. And what you can see here is that the major cause of death in patients, not surprising, with cancer is cancer, and cardiovascular disease only accounts for between 7 and 9%. And this is very different when it comes to the non-cancer population. And these are, again, patients with diabetes. And what you are seeing here is that cardiovascular disease accounts for 50% of deaths in men, and just a little under 50% are other causes. And of course, they're not dying from cancer because they're non-cancer patients. So the scenarios here are different, the settings is different, and the causes of deaths are different. we did a further piece of work in this area, looking at where diabetes may be giving cancer patients a worse survival. And in order to answer that question, you have to look at the effect of diabetes in the non-cancer population. And again, these are simulations, but they are true to the kind of values that we were seeing in the last set of slides, that at 10 years, you get in a cohort of patients with new diabetes, non-cancers, I should say, diabetes gives you a survival of about 89% versus 92%. But when you come to the cancer patients without diabetes, you have typically for all cancer comers, you have about a 55% survival. But you can get three potential scenarios in relation to the having type 2 diabetes. It may give you a scenario where it mirrors that in the general population, which would be the 43%, and that would give you an interactive term of essentially unity, i.e. 1, which is shown in the box below. But you may also get a scenario where, although patients with diabetes have a worse outcome, i.e. the 48%, in fact, the interaction is negative. So in other words, being a patient with diabetes, you have a worse outcome, but having cancer actually makes things a little bit better for you, because you actually have more contact with the health professionals and you have more attention to your diabetes and your general care of your diabetes. So although you have a worse survival, you actually haven't, the interaction term here is negative. And compared to what's happened in the general population, the non-cancer population, the effect of your diabetes hasn't been worsened. And you can have the third scenario where there's actually an additive effect. So having diabetes and having cancer, actually the whole thing is worse. You get suboptimal treatment, you have more complications, and you potentially do worse off, and that's the 39%. And that work is still ongoing, and we're still trying to tease out which of these groups patients with diabetes and cancer fall into. But these are the complexities that needed to be nuanced and worked out. So just a few slides on pharmacoepidemiology. I've alluded to the fact that the 26th of June 2009 was quite a famous day in the paper, not for a number of reasons. First of all, that was the death of a famous and iconic musician, Michael Jackson, but it was also the day when the stock shares in Sanofi fell by an enormous amount. They were reported to have fallen by the order of 3 billion, which just gives you a flavor for the size of the pharmaceutical company. And it was all due to the fact this link between insulin analogues and increased cancer rates, particularly breast cancer. And that's because when the analogues are made, they begin to look more like IGF-1, which is illustrated in this slide. And for that reason, they are thought to be more mitogenic. These studies were initially criticized, and it took a number of studies afterwards to use more improved methodologies to show the reasons why some of these studies were potentially methodologically limited. And there were two predominant problems with these studies. The first was one of a detection time bias, which is basically the coincidence of diagnosis of diabetes with the cancer. And that's why they looked like they were getting more increased risk. And when you take out these first 4 or 5 years out of the equation, these cancers often look like they're only marginally increased in these patients with these insulin analogues. The second bias that became familiar to the cancer epidemiologists at this time was that of immortal time bias. And this has two parts to it. This is all about you have to survive to get onto the drug. So let's say, for example, you start your diagnosis of type 2 diabetes, but it takes a number of years before you reach insulin and on insulin. And you have to count that period free of insulin as immortal. And that's what's shown here in this slide here, is that if you exclude that, as shown in the lower half, you get a selection bias. And if you don't include the events before that point, you get a misclassification in mortal time bias. So if you have a cancer diagnosis before that, it has to be included. And that's illustrated by these slides here. So once investigators started to take account of these two biases, and they will be discussed over the coming weeks in subsequent talks, the actual effect of insulin, and for that matter, the effects of metformin, which was thought to be protective, once you take account of these two major biases, the effects actually are very, very minor if they're there at all. And finally, to the question of genetics. And really, the big area of genetics in the last 4 to 5 years has been in this area of Mendelian randomization. And this is widely used both in cancer and in cardiovascular disease. So it's probably well known to the audience who are on here this afternoon. And there are two things I would point to in Mendelian randomization. So the Mendelian randomization is based on the fact that as we are conceived and in early embryonic development, the distribution of allelic polymers is basically, the polymorphisms, the alleles, is based on a random distribution. It's a random event which will determine subsequent traits. They will determine the color of our hair, our tendency to obesity. And we now know from large gene-wide association studies that there are traits for a number of things that are relevant to this story, including the traits of BMI, and importantly, in these 3 studies I'm showing here, the traits of insulin resistance. So what these studies have been able to do, and these are large consortiums, but they're mainly driven by groups led out of IARC, and the name of Paul Brennan, and the second name there you see Matthias Johansson. Those 2 individuals have been big drivers in this field, driving the consortia and driving the methodology. And what they've been able to show for 3 cancer types, lung, pancreas, and renal cell carcinoma, is quite a consistent story, that the traits that link with BMI show an increased risk for lung, pancreatic, and renal carcinoma. And they tend to do this. They share also the traits for insulin resistance, implicating insulin resistance in the mechanisms that cause these 3 cancers. So again, I will summarize my key findings, and apologies to the organizers if I've run over my 30 minutes. So we've looked at cancer-related, obesity-related cancers. Incidence and mortality are both increased in people with diabetes. We've looked at the story of anti-diabetes drugs, and I've also showed you some genetic work that implicates insulin resistance as a causal pathway. I hope that's been helpful, and I will now look at the chat and hand you back to Jette to chair things. Thank you very much for your attention.
Thank you very much, Andrew. Yeah, and I think while we are waiting for the questions, then I would like you to answer a few questions about the talk. So please have a look at the 2 questions that you see on your screen right now and answer them.
Sorry, Jette, I'm just still trying to get into mode here.
Yes.
And I can see there's a question from Lucas. So Jette, maybe we should.
Can you ask me that question?
Yes, you can.
Here we go.
Yeah.
Now I can get into the chat room now.
Hi, so can I ask my question or?
Yes,
Yes.
please
Yes,
do.
please.
Yes, sorry about this. I'm just trying to get into the chat, yeah.
I'm sorry, and I apologize if the computer dies. I don't have any more battery on, but I'll try. So I'm curious, and thank you first of all for a wonderful talk. I really enjoyed all of it. So I'm wondering why you think it is that women that are obese have more adverse outcomes of cancer and high risk of cancer, whereas men does not.
Yes, so thank you for that. And this is really because of three main cancer types, which are relatively common cancers. So there's postmenopausal breast cancer, there's endometrial cancer, and there's ovarian cancer. These are obviously female-only cancers. When we look at the links between BMI and these cancers, there's quite strong links, particularly in endometrial cancer, very strong links. So it's reflecting the fact that there is the mutual risk factor of elevated BMI. Having said that, these are also cancers, with the exception of ovarian, which have generally a reasonable outcome in terms of survival. So there is that balance. Yeah.
So just to follow up, do you think that it's obesity-induced elevated estrogens that might be causing this, or are there other factors?
Yeah, absolutely. Again, this is an important discussion. Although I have, because of limitation of time, I've limited mechanisms to insulin resistance. There are broadly three big mechanisms. There are more, but the three big hypotheses linking diabetes and obesity with cancer are insulin resistance, changes in the sex hormones, predominantly, as you say, estrogen and progesterone changes. And the third one is this subclinical inflammatory process, which comes with a lot of changes in cytokines and adiponectins and the like, which also drive an environment that can potentially drive cancers.
Right.
So yeah, I've no doubt about it that there are alterations there, yeah, in sex hormones.
Right. Thank you very much.
Thank you. And thank you for this great talk, Andrew. It was very interesting. And I don't think there's any more questions for now, so I will just answer or ask you a question. Do you think the diabetes medication is known also to be able to affect the cancer risk? What about all the new diabetes treatments? I have read about GLP-1 analogues and the newer formats, the combination drugs. What about these drugs? How do they affect cancer, and where are we heading in that direction?
Yes, so you're absolutely right. This area, over the last 10 years, there's a whole new literature that's expanding here. So some of this starts initially with all of these drugs as they come out, as you described, they're new. They go into safety registries where there's alert systems of side effects, adverse side effects. And some of these have highlighted links with cancer, for example, pancreatic cancer and pancreatitis and GPL1s. But when they've then subsequently tried to look at these in bigger data sets with appropriately long follow-up, you do need typically about a 10-year follow-up with these drugs. So some of these drugs are only reaching 10 years on the market. You need that follow-up to start seeing a signal. And if you apply the techniques that I talked about that reduce the biases, such as immortal time bias, such as detection time bias, you don't see a convincing signal as being the general consensus. But there's still work to be done in this area. As you say, some of them still need long enough follow-up.
Yeah, there's a lot going on there. Okay, it will be interesting to see what's happening. And we have a lot of questions now. I think the first one is from Liz in Oklahoma. So maybe you could unmute your microphone.
Hi. Yes, good morning or good afternoon. I guess I'm in Oklahoma, so it's morning for me. Thank you. This is a privilege to be able to join this seminar series from the US. I wanted to ask, so I noticed, there's a lot of heterogeneity in some of these risk groups, as you mentioned. And you spoke specifically about diabetes, which is a diagnosed illness, but I'm wondering if even before that, what are your thoughts on extending risk to people who haven't yet been diagnosed with diabetes, but may, we hear about this metabolically unhealthy phenotype that's characterized by hyperinsulinemia and, kind of a pre-diabetic state. And I'm just wondering about where the field is going in terms of extending the definition of metabolic function beyond just overt diabetes for looking at cancer risk.
Yeah, I think absolutely. I think there's a story that's beginning to play out there. So we can, if you step back from the diabetes population and you look at, as you say, this non-diabetes population, you can broadly talk about 4 categories: this normal weight, healthy, normal weight but metabolically unhealthy, and then the overweight obese, healthy, and overweight obese non-healthy, unhealthy, metabolically unhealthy. And depending on the cohorts, there's various ways of as you say, of defining them. Most of the cohorts are able to come, well, first of all, not all cohorts have collected sufficient enough data to come up with this definition. But the definition of metabolic syndrome, which includes waist circumference, central adiposity, insulin resistance, cholesterol measures, and blood pressure measures, start to get a distinction about this and start to get a division. And I think this signal is beginning to show stronger that you almost have a stepwise, that you can be normal weight but metabolically unhealthy, and you're still at increased risk of cancer. And I recently, well, there may be some authors on the chat this afternoon. I have in the last 4 or 5 months, I've reviewed a meta-analysis going into, I think it's been accepted as far as I remember, that addresses this very fact, and it's looking like a favorable story.
Okay, I can't wait to read that. Thank you.
Yeah, and it's as you say, it's all about targeting populations that may do better from interventions. Thank you to I've learned a huge amount from diabetes physicians. Diabetes physicians are able to identify this pre-diabetes condition and are able to intervene. And that's a very powerful tool that we don't have in cancer.
Right. I'm a cancer person, so I don't know much about diabetes, but it feels like there is lacking a definition of that pre-diabetic state that would be, when you're doing those big analyses with a lot of numbers, you have to assign people to a category, and categorical definitions seem to be kind of subjective depending on the study. So,
but the diabetes literature have far more trials than we have in cancer, which are able to identify pre-diabetes people, and with the endpoint of becoming diabetic, they are able to intervene and delay that onset, and that's quite powerful.
Thank you. And the next question is from Amanda in New York. If you're still there, Amanda.
Yes. Hi. Thank you for such a great talk. I'm Amanda. I'm an endocrinologist from New York. I'm interested in lung cancer, and I find it fascinating that the Mendelian randomization studies are showing a link between insulin resistance and lung cancer. And I know the epidemiologic data about the link between diabetes and obesity is a bit conflicting, and lung cancer is not listed as a diabetes related cancer. So I was interested in your thoughts on how smoking affects that picture, and if if there's really not if there's not really a link, or if it's really smoking is the major driver and metabolic disease is kind of in the background, and that's why we're not really seeing.
Okay, well spotted. It's great that people were paying attention on the slide. So I'm going to come back. Your explanation is very much to the mark. And I'm going to come back to a term which I should have mentioned in Mendelian randomization. And it's this concept of triangulation, which I'll come back to in a second. So you're absolutely right that when you look at studies that looked at BMI and the association with cancer incidence, lung cancer incidence, you're absolutely right that by and large, it shows an inverse association rather than a positive association. And it is long thought that this is a problem about confounding due to smoking. Remembering that smoking is obviously a strong risk factor for lung cancer, and people that smoke are by and large have a lower mean BMI. So when you look at non-smokers and the link between BMI and lung cancer risk, you by and large get a pretty flat or no signal at all, by and large. So these stories from Mendelian randomization are a little bit of a debate that why are they seeing this signal? And this is where the thing of triangulation comes in, and it's a hot topic when you're discussing the results of Mendelian randomization. The Mendelian randomization itself should not stand alone as a result. It should be consistent with the conventional epidemiology. And that is an inconsistent finding. So you're absolutely right. We cannot be 100% conclusive about that observation at the moment. But when we see Mendelian randomization giving us a consistent signal with conventional epidemiology, for example, with pancreatic and with renal cell carcinoma, using the principle of triangulation, we can be more confident that those associations are stronger in terms of causality.
Thank you. And then there's a question, the last one in the chat. Could you please comment on increased risk of burden of cancer in patients with diabetes from BAME communities of those from lower socioeconomic backgrounds?
So this, I'm not sure whether the BAM is just something that the UK used, or I hope, I think North America used this abbreviation as well. So this is Black, Asian, and minority ethnicities. So again, we've learned a huge amount from the diabetes literature, and now, of course, more recently, this population is impacted upon in the COVID pandemic in a differential manner. The literature link for cancer incidence in this population is far more sparse, and it's hard to come up with really strong conclusions. There are a number of paradoxes that we can have some reasonable numbers on. So, for example, we know that the Black men are at increased risk of prostate cancer, but we have this paradox that men with diabetes are at reduced risk of prostate cancer. And there are a number of explanations that may relate to hormonal changes, may relate to reduced testosterone levels. As explanations, there are explanations around screen detection is more difficult with PSA in men who are obese and with diabetes, because again, like for like, they have a lower mean PSA. So there are a number of caveats and complexities to this area that is an area that is really an unmet need for research. And I suspect this individual may be interested in investigating, may already be starting to look at this story, because we are looking for big cohorts with these patients with good detail of ethnicity, their diabetes status, their BMI status, and cancer risk. If anybody has that kind of cohort, this is a really ripe area. The multi-ethnicity group led out of Hawaii and Los Angeles are answering some of these questions, for example.
Thank you, Andrew. And I think we have spent all the time, and there I can't see any more questions. So thank you so much for participating.
Sono.
Can you see one more?
Beskar, he just raised his hand.
Okay.
The one that asked the question before. So maybe you have a comment.
Yeah, please come back.
Would you please unmute yourself to ask your question?
Hi, Andrew. This is Sonu Bhaskar here. I'm a neurologist from Sydney in Australia. And the last question was from mine.
Yeah.
So it's 2 o'clock in the morning, so forgive my little bit of
Thank you for joining us.
Yeah, so the question is with regards to Southwest Sydney and also in UK, realize that the impact of diabetes on the BAME communities and people from lower socioeconomic background has been politically and otherwise, from a health policy perspective, getting a lot of momentum. And I would postulate that the increasing cancer risk in these populations also may have some kind of association with a previous history of diabetes. So quite interesting from a health policy perspective, how do you think that could be tackled? And second, with the recently released guidelines from European societies about the efficacy of the combination therapy in diabetes patients, how do you think that would play out in terms of risk managing these patients and hence reducing the risk of cancer in future?
Yeah, a huge number of questions there, all hugely important, and we need big data to look at this. What we don't have at the moment, and you touched on something that I didn't get a chance to talk about, is at the moment we have no clear evidence or no clear signal that better controlled diabetes impacts upon cancer risk. We don't know that for certain. It's interesting to postulate it, and of course I've shown you slides that the inference is in the trend studies that I showed you that better treatment of diabetes has improved cardiovascular deaths, reduced cardiovascular deaths, and there's a reduction in cancer deaths as well. We don't know how much of that is due to better diabetes control or better cancer control. So there's a lot of work to be done there. I think I'm answering your question by giving you more research. But I think that's the best I can give you at the moment.
Thank you.
And I think that was the last question for today.